Thank you very much for your attention.
Thanks so much, Fabio, for this interesting presentation. I can read a lot of questions here. We'll keep the questions until the end of session. And I would like to remind you, if you have any more questions, you can type them in the question box. We'll try to address them within the time frame, and the remaining questions will be addressed and posted offline on the EACTA website. Now, I'm delighted to introduce the next speaker, Professor Mert Senturk from Istanbul University, Turkey. He's the chair of EACTA Thoracic Subcommittee, and he's the leader for implemented recommendations from EACTA for patients undergoing thoracic surgery during era of COVID-19. And he will talk about thoracic anaesthetist, how to be prepared for COVID-19 patients. Please start, Mert.
Dear friends, my name is Mert Senturk. I'm coming from Istanbul, Turkey, and I'm going to talk about the preparation of ourselves, not the patient, for the thoracic operation of a patient with COVID-19 or with the suspicion of COVID-19. I don't have any financial support or any other conflict of interest concerning this presentation, but I have to thank to my thoracic friends, especially Mohamed and Tahan, for sharing their slides, photos, data, etc. So the agenda is, as you can see here, how first the preparation, and afterwards the perioperative care. I'm going to focus on tracheal intubation and lung separation, and also the challenges about the one lung ventilation. Everybody asked me that they do not do any thoracic operations in these corona days, and therefore this cannot be a challenge, but we have now more than 1 month already with the COVID, and we can see that it's not a sprint, it's not a short distance run, it's rather a marathon, as we can see here. And as we slightly reach the peak of the pandemics, we have started also the elective operations, especially for carcinoma patients, and therefore it's not very rational to ignore the non-COVID operations too. We have recently prepared a recommendation, so-called a preliminary recommendation for the thoracic operations in COVID period, and these recommendations involve not only the COVID-19, diagnosed COVID-19 patients, but also the suspected, the patients with the suspected diagnosis. And therefore, I have to underline that these presentation will also include the patients only with suspicion to have a COVID-19 patients. With this regard, we have to say, we have to consider, we have to assume that all the patients we have to anesthetize in this period can have some COVID infections, and therefore they are under risk of having a COVID infection. So we can start with the preparation. We all know that the mean recommendation for the operation and intubation is to have negative pressure rooms. But we know that not only in my country, in many countries in Europe and all over the world, intensive care units have some negative pressure rooms, but not the operating rooms. And therefore, we have to assume, we can consider that we have to do it without the negative pressure rooms. What if we don't have any negative pressure rooms? We have 3 recommendations. First of all, the level of personal protection equipment that we have to wear should be increased. Let's say from only a face shield, we can go to the helmet, from respirators in place of masks, etc. Or the intubation can be performed in a negative pressure room, followed by the transfer to the OR. This is, in many places, including my institute, not a good idea because the distance from the, let's say, intubation room to the OR is not worth to take these risks. Or we can have, if we have rooms with the positive pressure, as many ORs, the room can be put under the least possible positive pressure and the rest of the unit under higher positive pressure. And the doors should be kept closed so that the high exchange rate of air in the operating theaters limit the dispersion. The dispersion is the key word here of aerosols outside the theater. How do we diagnose a patient with COVID? We have seen in this period of more than 1 month that the diagnosis is not very easy. We have done our diagnosis with the routine swab testing, but we will see that swab testing is associated with a high rate of false negative results. My country, Turkey, is probably one of the few countries that a routine computer tomography, CT, is the part of the diagnosis because we have to admit it's quite cheap here. And then the diagnosis with the CT is more reliable, we have to say, than the diagnosis with the swab test, than the PCR. Moreover, we have to have a screening checklist. And even if we have no symptoms at all, even if we are dealing with a totally asymptomatic patients, still it's a good idea to use patient consent test, patient consent text. This is the Turkish version here, to avoid any post-operative malpractice suing problems. We can see it here that, as I said before, that the swab tests are associated with a very high false negative results, and therefore we cannot trust too much to the results of these tests. How about the flu plan? The general recommendation of many societies, airway societies, is that to have 3 anesthetists, 3 attendants at the same time for the intubation. But as we prepare the manuscript of the article, we have noticed that in these times to have 3 people in the same OR appears to be very irrational. And therefore we have decided for a compromise to have only 2 attendants for the intubation. All the other people, including the surgeons, should wait during this time, so with the PPE outside the room. We have to have a runner for an emergency case, and you can see it here. We have to have also an observer to check the donning and doffing of the personal protection equipment. I don't want to go in further details about the PPEs, but we have some levels of PPEs.